Good morning, everyone, and welcome to Montiart. Today, it's my real pleasure to introduce you Professor Agustin Kwan, who is our guest for today. He will talk about patient selection for MR therapies. Agustin is a really good friend and also expert in interventional imaging, especially in the structural field. He's very involved in both the clinical and the research side. We had the pleasure to meet when he came to spend 1 year doing research at CRF here in New York, and then he came and joined us also in Monty for 1 year. Thank you, Agustin, for being here today.
Thanks, Andrea, and Azim and all the team for the invitation. It's a real pleasure for me to be there. It reminds me when I used to come early in the morning to follow these talks. So today, indeed, we're going to speak about patient selection for MR therapies. I'm not going to speak too much about the echo stuff. It's going to be more about discuss the clinical aspects. Okay, so first of all, I wanted to start with the guidelines because, of course, you know that we need to separate patients with primary MR and patients with secondary MR. It's definitely not the same population and not the same therapeutic solution. First of all, if we speak about patients with primary MR, we need to treat patients with symptoms, of course, and patients if they have no symptoms, if they have LV dysfunction. And we have this definition provided by the American and European guidelines. And of course, in this population, the mitral valve surgery is the first-line therapy, but there is room for edge-to-edge repair, as you can see in the American and European guidelines, if the anatomy is favorable for this population. For secondary MR, it's more complicated. Of course, we need to treat patients with guideline medical treatment. There are less and less surgery, I think, in this population. There are room for TEER in both American and European guidelines, but in the American guidelines, few place for other transcatheter therapy. But what is important to emphasize is if we stick to these guidelines, if we look at the publication from the Mayo Clinic team in the Lancet 5 years ago, only 15% of the population with severe MR and symptoms are referred for surgery. And not surprisingly, the overall survival is lower in this population compared to an expected survival. So what can we do to improve this under treatment? First of all, we can try to propose something earlier, and there are more and more data supporting that early surgical intervention may benefit in this population with primary MR. And there is an ongoing RCT in France when we randomize patients on early surgery versus medical treatment. We are expecting to finish the inclusion in 2 years and get the data within the next 5 years. But most importantly, we have this development of new technology. We can have transcatheter mitral valve repair. It can be edge-to-edge repair, caudal repair, and indirect or direct annuloplasty. And of course, all these TMVR devices. And I just highlighted in red the cases we've done in Lille, iLife, Intrepid, Cepha, and Tendyne. I saw that, guys, you did an amazing AltaValve case last week, but we can discuss about all this technology afterward. So I wanted to start with these 3 patients. We have patient 1, 2, and 3, and as you can see, it's always TE exam, and on the left for each patient you have the 2-chamber view or bicomissural view, and we did a bioplane analysis on the right with the 3-chamber or LVOT view. And we're going to go deeper in the analysis of the anatomy of these patients. So patient number 1, as you can see, patient with a prior TAVR, patient with a slight amount of calcification at the base of the leaflet, and you can see pretty well a P2 prolapse with a fade leaflet and not a very important extension of the jet. And in this population, of course, 3D echo is really interesting. We can use color, we can use transillumination, and you can see pretty well the P2 prolapse between P2 and P1 actually, with a small amount of calcification at the base of the leaflet. And we did edge-to-edge repair in this patient, and we were able to achieve a very good result with trace residual MR, no stenosis, as you can see here, and important change in the flow in the pulmonary vein. Conversely, we had this patient. This patient was a patient with an ischemic MR, with a restriction of the posterior leaflet, as you can see, but most importantly, a small, let's call it cleft-like indentation between P2 and P3. And unfortunately, this patient has been hospitalized a couple of times for acute heart failure. It was, of course, at probative risk for surgery, and we had no choice to propose an HOH repair. And we were pretty happy with the grasping in the beginning, as you can see on the left. But when we released the clip, I think we had, let's say, between 1+ and 2+ residual MR, because we had less tension on the clip, less tension on the valve. And indeed, if you look at this analysis from the left atrium and also from the left ventricle, we were very close to the cleft-like indentation, but we were not able to close completely this indentation. And look at this patient number 3. It's also, as you can see, an ischemic MR with a poor left ventricular function, a patient with a prior occlusion of the circumflex artery, and a very important restriction of the posterior leaflet, very short posterior leaflet, and a false prolapse of the anterior leaflet. Unfortunately, the posterior leaflet was really, really short, and as you can see here, there is a hole between P1 and P2. It was the cause of the regurgitation. And for this patient, we were not able to propose a repair, but we tried to replace the valve using the only device with a CE mark in Europe. It's a Tendyne device developed by Abbott. And as you can see, it's a particular device because we have a tether and a pad. It's a transapical access. And we have also this D-shape anatomy of the device. And we're going to see just after how can we place this device. First of all, we need to perform a CT scan. We need to record several parameters like the trigon to trigon distance, commission to commission diameter, the area, the perimeter, and the AP diameter. And we have a valve sizing calculator developed by Abbott. And for this patient, we tried the device with let's say between 10 and 20% of oversizing, and it was a 37L standard profile. And then we put the phantom of the device in the CT scan, try to assess the neo-LVOT area, so the LVOT after deployment, and the A2 clearance. The neo-LVOT was measured at 582 millimeters square, so we were far from the cutoff proposed by Abbott, which is 250 millimeter square. Of course, we try also to modelize the transapical axis to be sure to be perfectly perpendicular to the plane of the annulus. And we did this implantation. You can see pretty well the what is called the finger poke of the cardiac surgeon at the apex of the valve. It's really important to separate the true apex of the valve of the left ventricle, as you can see with the red dots, compared to the target, which is what the green one. And then we put a guide through the mitral valve toward the left atrium. Of course, we can use MPR to be perfectly aligned. And then we advance progressively the catheter toward, let's say, between 1 and 2 centimeters, the plane of the annulus into the left atrium. And then we started to deploy the valve progressively. As I mentioned, it's a valve with a D shape, so we have to put this blind part of the D in face of in front of the aortic valve, which is the anterior part of the valve. In the end, we were able to deploy the valve with very good results, no residual MR, no stenosis, and very good deployment of the device. So, of course, we all know that mitral edge-to-edge repair has been the first line therapeutic solution. with more than 200,000 implantations so far worldwide. But we need also to keep in mind that not all patients are suitable for mitral tear. On the left side, you have patients like our patient number one, patient, let's say, ideal, optimal for beginner centers, not like a Monty, of course, with, let's say, a pathology in the central segment, A2P2, with no calcification, with enough area, no stenosis, meaning a mitral valve area more than 4 centimeters square, with enough posterior leaflet, more than 10 millimeter, normal mobility, and not too important flail gap or flail width. On the opposite side, on the right side, we have like our patient number three. When we have a grasping zone with calcium, a stenosis, meaning an area less than 3 centimeters square, a very short posterior leaflet of 7 millimeter, or a cleft, a rheumatic disease, or a bone disease with multiple segments. These are, let's say, probably more challenged. And in between, we have less ideal, more challenging cases, but we can propose edge-to-edge repair in this patient. This is an update of the classification proposed by our German colleagues and produced by Mauricio Taramasso in Neurointervention in 2019. But more recently, Jörg Ausleiter proposed another classification, which is based on a couple of things, but probably because we gained expertise in that field and we had also several devices iteration. So they proposed not a 3-grade classification, but a 4 grades. Now we can propose also this red change actually on the right. The definition of, let's say, hard or impossible anterior is a posterior leaflet less than 5 millimeter. And as you can see, Barlow disease is not a red characteristic now, it's more an orange characteristic like clefts. So keep in mind this suitability for mitral tear. What is the clinical impact of this classification? Paul Soraya's team published this in Second Intervention 1 year ago, and they looked at the 3-grade classification, patient suitable, intermediate, or not suitable for edge-to-edge repair. And they found that, not surprisingly, non-suitable patients had lower MR reduction, of course, higher rates of 30-day MACEs or technical or not technical success, but most importantly, we had a lower survival in non-suitable patients. And more recently, we did this analysis based on the primary registry, so only patients with primary mitral regurgitation. We separated patients in green, yellow, and red groups, and we found that nowadays we had no difference between the green and the yellow group if we look at the outcomes after 2-year follow-up, meaning that probably now we gained expertise and we were able to achieve very good results even in the yellow group. So probably in the future, I do believe that we need to separate not only in 3, but in 2 groups, non-suitable and suitable patients. One really important thing to keep in mind is when we think about edge-to-edge repair, we need to think about the residual MR we will be able to achieve, because we know now that even patient with a 2+ residual MR, it's a Kaplan-Meier curve in yellow here, data from prime MR once again, and this patient had a lower survival compared to patient with a 1+ residual MR or less, as highlighted by the Kaplan-Meier curve in green. It was the case for all-cause mortality, but also for heart failure hospitalization. And I wanted to present you this case once again. As you can see, it's a complex case because we had a degree of classification. It's a MAC case, let's say, but not a classification of the whole annulus, let's say. And within the classification, at the posteromedial parts, you can see a small prolapse with rupture cords. So in this patient, we try to propose a TMVR again, but if we look at data from the Choice MR registry, so it's a biggest registry for TMVR screening so far, we know that only 2 out of 3 patients screened from TMVR are deemed ineligible, and it's regardless of the device chosen. And what are the criteria? What are the causes for ineligibility for TMVR? We have 3 big reasons. The first one is too large annulus. The second one is a small annulus and the risk of no LVOT area. And of course, we have MAC patients. It has been perfectly aligned by this editorial by Andrea. So in this patient, we were not able to propose a Tendyne device because of the risk of LVOT. So we proposed a CFA, which is a transseptal valve replacement system. We did this first implantation with Thomas and Juan Granada. It was 6 years ago. And it's the same. We did an analysis of the CT scan. As you can see, it was a severe MAC. We modelize the device. We look at the transseptal puncture, and of course, of the inferior vena cava measurement. And at the end, we were able to achieve a very good implantation with a trace residual MR because of the calcification. And indeed, MAC is an issue in that field. We had this patient a couple of months ago, a 65-year-old patient with a prior cancer and Hodgkin lymphoma. He had radiotherapy. He has been operated before for a surgical arterial replacement and CABG. And we had, as you can see, a very important fibrosis and calcification of the mitral valve with, let's say, mild to moderate MR. You can see pretty well the huge amount of calcification on the medial part of the valve with a very small mitral valve area, 1.5 centimeters square. And of course, this patient is not suitable at all for edge-to-edge repair. And we tried to propose for this patient a compassionate use of the Tendyne device. It was the only available for us so far. So first, we balloon the valve on the medial side, try to open a little bit the valve. And we did a second balloon inflation, but on the medial side of the valve. And we deployed once again the catheter for the Tendyne system. Once again, it's an transapical implantation. And in the end, we were also able to have a very good implantation of the Tendyne system with no residual MR. The gradient was at 3 millimeters of mercury in the end, and no LVOT obstruction. And the patient is still alive so far. So being said that, of course, mitral annular calcification can be an issue in the selection of the device. And using the choice of my registry, once again, we look at patients with echo and CT scan analysis. And we had we divided the population in 2: patients with no or mild MAC, 222 patients, and patients with moderate and severe MAC, 57 patients. And as you can see, the rates of MR elimination, symptom improvement, and survival were similar for patients with no and mild MAC on the left, and those with moderate and severe MAC on the right. Meaning that TMVR in this population can be a solution, but of course, in moderate or severe MAC, we had higher rates of, let's say, post-procedural complication, meaning major bleedings, and acute kidney injury, which can be related to the general condition of the patient. So it can be a suitable solution in the future to think about treating a MAC patient using these devices. But for TMVR, we are future challenges. Of course, I presented you the only device with a CE mark in Europe so far, which is a Tendyne, and which is a transapical TMVR system. But we are moving more and more toward the transfemoral TMVR solutions. The rates of technical success are around 84% for these 2 techniques, with, of course, less mortality and less conversion to surgery in transseptal devices. Another solution try to prevent the risk of alveolar obstruction. As we mentioned, this is a very important risk, is to work on the interior mitral leaflet. We can have several solutions like the lampoon, like the Batman, like a anterior leaflet resection, or TMVR device-specific designs to prevent this kind of alveolar obstruction. And of course, we can propose a treatment of the basal septal hypertrophy, like an alcohol septal ablation or a sesame, like electrosurgery. And finally, we need to better understand the unsuitable patient. And we did this clustering analysis on the choice MI, and we found two big groups of patients that were not suitable for anything. I mean, TMVR, Bela tear surgery. So we had no choice that treating them with medical treatment so far. We have group number one, patient with, let's say, primary MR, women, old, frail, MAC MR related pathology, and the fellow group number two in red, patient with secondary MR and big left ventricle and very poor left ventricular function, meaning that the technology needs to propose solution for these two phenotypes. And Andrea published once again this important summarize of the challenges of TMVR for MR. We need to, in the future, to have wide range of valve sizes with a small valve profile, with compatible valve anchoring and design. And of course, we need to move toward a transseptal approach to avoid patients with a very poor left ventricular function. So I wanted to present you these criteria, which are mainly anatomical criteria for patients with primary MR. But of course, we need to speak about secondary MR, which is for me a very particular case. Of course, we don't have only one type of secondary MR. We have patients with ventricular functional MR, patients with ischemic MR, with most of the time akinesia of the posterior papillary muscle and very important tethering of the posterior leaflet, leading to a jet towards the posterior lateral part of the left atrium. And now we have patients with atrial functional MR, normal LV function, but very dilated left atrium and mitral annulus. And you also know that we had conflicting data regarding the treatment of this population. On the left, MITRA-FR, a French RCT published by Obadia in New England in 2018. Let's say, improvement of the survival in the intervention group. Conversely, Gregson published the same year, same journal, data from COAPT showing a very important reduction in the rates of atrial hospitalization in the device group. So if we compare MITRA-FR and COAPT, one thing that has been put forward to explain the discrepancies between the two groups and the two trials, first is the rates of MR reduction, which was actually not so, it was very close. But one thing that we put forward is the GGMT, because in MITRA-FR, it was an adjustment by the site investigator, like to stick to real world practice, compared to COAPT, where all the adjustments were reviewed by a central committee. But if we look at the rates of the treatments between MITRA-FR and COAPT, actually, I don't believe that patients in MITRA-FR were less treated with medical treatment compared to COAPT, with same rates of all the medicament drugs for heart failure. But what important thing is, if we look at the rates of moderate MR, we had higher rates in MITRA-FR with very big left ventricle, and the LV endosteric wall volume, the mean were higher in MITRA-FR compared to COAPT. And that's why we had this concept of proportionate or disproportionate functional MR proposed by Paul Greben and based on the Golin formula. So in patients with MITRA-FR, we had a patient with probably less severe MR and more dilated left ventricle. And if we put on this figure the effective regurgitation orifice area and the LV endosteric volume, the correlation of the linear regression between ERA and LV endosteric volume is 0.13. And of course, in patients with mitral FR, this ratio was lower than 0.13, and in COAPT, this ratio was higher than 0.13. And interestingly, if we look in COAPT, the subgroups in COAPT, the only subgroup of patients who had proportionate MR, it's the orange circle, showed response to TEER similar to those in the mitral FR trial. So this ratio between ERA and LV endoscopic volume is really interesting to stratify the risk of this population. And we had data also, not from RCT, but for real world and real life registries from EuroSMR, and they did exactly the same. They compared patients with mitral dominant disease, patients with left ventricular dominant disease, and patients in between. And they found that they were able to achieve similar results, meaning that the rates of 1+, 2+ residual MR were similar at discharge and at last follow-up between patients in the mitral dominant group and patients with the left dominant group. But if we look at the mortality at 2 years, patients with the left dominant disease in blue had a higher mortality compared to patients with a mitral dominant disease in red. This is why when we speak about treating these patients in France so far, we are allowed to propose a H2S repair only if we have patients like the COAPT criteria, not like mitral FR criteria, meaning patients with a secondary MR at high risk, ERA more than 30 millimeter square, with not too extended LV disease, LV endoscopic volume index lower or equal 96 milliliters per meter square, patient with acute heart failure within the past 12 months despite guideline medical treatment, and CRT and or revascularization. Of course, I wanted to present you this very interesting editorial published by Andrea and Azim a couple of weeks ago. They looked at the 4-year survival after mitral TEER in COAPT and EuroSMR, and it's important to emphasize the independent predictor of 5-year survival after mitral TEER. You have age, of course, kidney function, the rates of residual MR, and of course, the LVEF and the COAPT eligibility. So I do believe that it's really important to propose this therapy in patients with not too advanced left ventricular disease. Finally, just a couple of words about TMVR in patients with secondary MR. We have this data from Choice MI where they compared the outcomes in Choice MI patients and patients were matched with EuroSMR, and they found that patients who underwent TMVR had better improvements in NYHF functional class at 1 year, and let's say similar survival after the 30-day landmark analysis. Of course, it's a transapical access, so it can be a therapeutic solution for our population. And once again, they did this propensity matching between Choice MI and COAPT patient, patient under guideline medical treatment, and they found that TMVR was associated with lower rates of heart failure hospitalization compared to GGMT in this population. So in conclusion, I do believe, of course, for patients with severe MR and symptoms, surgery remains the first-line therapy. But as I mentioned, only a few proportion of patients are treated so far. So we need to find an alternative solution. MTEER is a safe alternative solution in high or probability risk patients. But if we can achieve a very good results, and I do believe that in 2025, a good result is a residual MR less or equal 1+, we can propose TMVR in suitable patients. So far, let's say only a third of patients screened are eligible for TMVR devices. We only have transapical access available in Europe outside trials, of course, but we are waiting for transseptal TMVR devices. And I do believe that secondary MR with a very important LV disease and MAC patients are very separate populations with very different phenotypes. Thank you very much.
Thanks, Agustin. This was a really brilliant talk. You covered everything for mitral disease and mitral therapies. Now we will have some questions. Maybe I'll start with one, and then we'll see if Pierre and other people will have more questions for you. So I know that now there is more and more evidence. This is just like a personal question. I know there is more and more evidence on the benefit of reducing MR, but still MITRA-FR was a French-based study. So how is in France now the referral for mitral therapies to transcatheter procedures? Do you find it difficult, or has it changed over the years? Is it different for primary and secondary MR? What is your experience?
That's a very good question. Of course, in the beginning, a couple of years ago, we treated mainly patients with secondary MR in France compared to primary MR. I don't have the exact rates, but I know that now in France, we are treating more patients with primary MR than patients with secondary MR. That's the third thing. The second thing is, since MITRA-FR and COAPT, we had more and more treatments like EGLT2 inhibitors, like Entresto, like a couple of RNI that are useful to, it has been proven to reduce MR severity, but only at 1 year. We don't have data later than 1 year. So now we are very strong heart failure teams that are following the patients in my institution like every month. And once they are at the end of the medical treatment, they are addressing the patient to propose something. That's the first answer. The second one is sometimes you can propose H2S repair in this population just only to improve the medical treatment. So that can be useful also. And the last point of my answer is that you know that we are Reshape 2 now, that has proven a very important improvement in survival in patients with, let's say, moderate secondary MR. So I don't know where these things are going, but I mean, in France, we are treating less patients with secondary MR now, but it's still a solution, I do believe, for our population.
Yes, I really liked your point because it's really a collaborative effort with our heart failure colleagues. Sometimes the end of medical therapy is not really the end. We've seen this with studies. If we improve MR, then they can push more on medical therapy, and then patients will benefit more and more. So I think it's something that needs to be always considered when we are seeing these patients. Let's see if Pierre, would you like to ask any question to Agustin?
Yeah, no, Agustin, really great presentation. You spanned the whole range of MR treatment, surgical, transcatheter, repair, replacement. It was really, really nice to hear from you. I have just a couple of points. I'd say one for primary MR and one for secondary MR. So, and what made me think is the design of the primary randomized controlled trial. So the plan, and they're currently randomizing patients older than 60 years old to mitral TEER or surgical repair. And this is all primary MR. And I don't know the expected completion date, but it really, really makes me think, and I would love to hear your thoughts. What do you think about a first approach in young patients that are suitable to TEER with actually a percutaneous low-risk procedure? Because when you also speak to surgeons, and I would not to know also if you had any kind of conversation in this regards, when you have a clip and you undergo surgery after failed TEER, it doesn't look, as far as I've been told, that it's too difficult for them to actually remove the clip without distorting the anatomy. So one provocative thinking, it would be, I can just go straight to TEER with a young low-risk patient, hopefully, and I get a better result. But even if I don't get a good result, and then I might need to undergo a surgery after, it might not be that bad, and just underwent a very low-risk procedure that might have benefited the patient and avoided one surgery. And the other question, just so that we go for functional as well. My other question was, which one is the competitor of TEER in functional MR? Is it surgery itself? Is it TMVR? Is it just some kinds of TMVR that have some specific designs that maybe interact with boards and maybe can give us some kind of remodeling of the ventricle?
Very good points, Pierre. So first question about primary MR. For sure, we need to keep surgeons on the loop, and we have surgeons in Lille that are able to achieve very good results with mitral valve repair. And when we have young patients with low risk, of course, I mean, the rates of complications in our institution is very low. That's the first thing. And you know that mitral TEER can be a solution, but we're not treating one thing which is really important for me and really important for the surgeons too, is the mitral annulus. You know that the base of the mitral valve, surgical mitral valve repair, is to put a ring. And even in patients with Barlow disease, sometimes they only put a ring, they close the cleft and put no cords at all. And this is respect as much as they can the anatomy, and we have long-term results with very good results. So now we have surgeons, of course, are doing HRS repair, and it's easier for us to discuss because we're sending the patient and they choose the best therapeutic solution. You know, we don't have any competition between the surgery and the MTR. So I do believe there is room, of course, for surgery and for H2S repair for this population. But if you can achieve very good results with surgery, which is complicated, of course, if you put a clip first, because you have to replace the valve, and we know that the complication with replacement are higher than after repair with surgery. And the second question was about secondary MR. I do believe that in all of frail patients with a P2 prolapse, you put one clip is 30 minutes. You have very good results. You know that the lifetime will not be so long, so it's a very good thing. Now we have combined device that try to treat the annulus, treat the leaflet, treat the cords, but they're still under investigation so far. But once again, I do believe there's no competition between devices. It's not like TAVR. We won't find only one device that will erase the others. You know, we have to have several therapeutic solutions in our arms and to choose the best therapeutic solution for the patients.
Thanks,
All right, thanks.
I see that we have Azim Latif just joined us. He's raising a hand. Would you like to ask a question?
Well, actually, I joined some time ago, but that's fine. Hey, Agustin, so nice to see you, my friend, and thank you for doing this. We always learn so much from you. So I had a couple of questions. You know, one of the things I'm struck by is what you said is happening in France is that you're doing a lot less patients with secondary MR. But I think this is a worldwide phenomenon. You know, certainly in Monty, our patient profile has gone from when I started, your 2/3 were FMR, now 20% FMR. And I think a lot of it has to do with GDMT. I think guideline-directed medical therapy has become very good. But I also think, you know, now that we have COAPT and Reshape, we also need to change our thinking. You know, those of us looking after heart failure patients, you know, you don't have to think of mitral clip only when you've exhausted all the drugs for a number of years and the patient's failing. I think there are times even as you're adjusting drugs, and if a patient's very symptomatic, you know, this therapy can help GDMT, because there are a lot of patients who can't tolerate their doses of GDMT until they clipped, and suddenly when they clip, they can tolerate their doses of GDMT. I don't know, any thoughts?
I fully agree with you. We had this discussion a couple of weeks ago with Stefan Anker, all those people who led the Reshape too. you know that in the heart failure recommendation, we have 4 fantastics, let's say. I do believe that in the future will not be 4, but 5. And I think that mitral TEER could be one of the therapeutic solution within the guideline medical treatment, let's say, field.
Yeah.
And of course, we need to propose this if we are as any drugs for heart failure patients.
Yeah, absolutely. So another question I had for you is, I mean, you went through the whole sort of armamentarium of, repair, replacement. Do you think when it comes to technology for the mitral valve, we have everything we need, or do you think there are still technologies out there that are important that we're missing and we should be investing in trying to bring to clinical use?
That's a very good question. If we think from a patient perspective, of course, we don't have everything we need because, I mean, only a few proportion of patients are treated so far. And I refer for all these transcatheter techniques. And even if they are referred, only a few proportion of patients are eligible for this therapy. One of the things that can be a game changer for me is all this new technology who is coming from, let's say, an annular or atrial implantation, just to avoid this problem of too large annulus or LVOT obstruction. Because of course, the LVOT obstruction is a big issue. And also we need to think about MAC patients. We are seeing more and more patients with MAC, not like the one I showed with only very severe MAC and mild MR, patient with moderate or severe MR and an amount of calcification. So we are missing something for sure, but I think that new devices are coming. I'm waiting for the data, for instance, for mitral valve, with not supposed to have less LVOT obstruction. But within the future, but for sure, we need to move toward transeptal devices.
Great, thank you. Yeah, no, I mean, I agree with you. I'm hoping, I haven't given up on the toolbox approach to mitral valve disease. I think you're right. Annuloplasty is an important part. I'm still hoping we're going to see transeptal neocords in the future as a therapy because despite, we'll have to see what the data for primary is, but I'm still reluctant to put a TEER device in a young patient because, maybe there are a few surgeons in the world who say they can remove a TEER device, but I think most surgeons that we get to work with in our centers are probably going to end up replacing the valve after TEER. So I think be able to, not damage the leaflets is, I think, potential advantage in the future. Agustin, thank you very much. Appreciate the comments.
Of course, you're welcome, Azim.
Agustin, just to be in line with these great questions, I wanted to ask you something because I'm seeing nowadays more and more cases being presented at congresses, conferences, and being published on patients undergoing edge-to-edge repair. And then if the device fails or there is still significant because there is significant residual MR or for any other reason, the mitral clip is removed in a transcatheter way with these new devices that can capture the clip. And then a new approach can be applied, either replacement or even another transcatheter procedure. What do you think about this? Do you think this can change the paradigm of just TEER versus TMVR or other therapies and having like a sort of sequential approach in our patients, or what's your idea?
Honestly, I don't think that the solution of putting a clip, say, okay, let's see what's going on. If we can achieve a good result, we are happy. If not, we can remove the clip and put a TMVR device. I think it's about patient selection once again. If you have a good expertise, very good patient selection, most of the time, of course, not always, because sometimes you put a clip and you don't know why you have another jet on the left side, and you have to struggle with these new jets. but it's all about patient selection. And I think you mentioned this. You want to remove the clip, so meaning it's a failure. So I don't think it's a very elegant approach to think about one failure, then move to another one. It's like a two implantation and one for nothing. So no, it's all about patient selection.
Perfect.
And now we have, I mean, for the mitral clip, we have 4 devices. We have Pascal. Even for edge to edge, we can choose between this edge to edge field, try to find the best approach for the patient. So we have still a lot of things to learn from these devices and this step-by-step approach.
Thank you. Antonella, do you have any question?
Yes, hi. Thank you. Hi, thank you very much for the lecture. My question is more like practical. From an imager standpoint, how much the measurement you take before like TMVR and your like procedure are dependent of volume status, and if you do any kind of pre-medication before taking this like doing it in the CT or the TE.
So you mentioned about for TEER or for TMVR?
For TMVR almost.
For TMVR almost. We have shown, we have published that the analysis of the annulus using 3D echo showed a very good correlation with CT measurements. So what we are doing now, if we are doing a 3D analysis of the annulus, we are doing the AP, commissure to commissure, the area, and so on. If the patient is within the range, we are moving toward a CT. But if the patient is very far from the ranges, of course, it depends on the device. We want to avoid any vein CT for these frail patients. Regarding the
sorry, yeah, sorry. No, go ahead.
Regarding the status, it's not like tricuspid valve disease. When you put some diuretic, you put some fluids, the TR severity is changing, and the analysis is changing a lot too. For the mitral valve, it's not the case actually.
Okay.
So we are doing the patient in the echo lab, not under general anesthesia, and that's it.
Okay, thanks.
Excellent, Agustin. I see there are no more questions, so I really wanted to thank you so much for giving us your time and this talk that was great, very nice discussion. And hopefully we can do this again in the future when things will be changed. We will have more therapies and maybe we will discuss about new concepts about treating MR patients. Thank you, Agustin.
For sure. I just wanted to add 2 things, Andrea. Of course, I would like to congratulate you, Azim, and all the team for all the things you are doing in the field. It's really you are an inspiration actually for all of us. And I will also like to thanks Azim and the team for having welcomed me so well when I was there. I was immediately part of the family, and it was really important for me. So I would like to publicly say thank you for that.
Thank you, Agustin.
It was a pleasure to have you as part of our family, Agustin. And remember, you unfortunately, this is the kind of family you can't get divorced from, so you stay part of the family forever.
Okay, that's fine. I will tell my wife, but that's fine.
Okay.
Great.
Stay well, my friend. Take care.
You too. Take care. Bye-bye.
Ciao, ciao.
Thanks.
Merry Christmas.